Yes. Good evening, everyone, and thanks for joining in tonight for this Thrombosis Canada webinar on thrombosis COVID-19 update, expert perspectives on inpatient management. All right, so I am Marie-Pier Arsenault. I trained at McMaster University in the AFC Thrombosis program 2 years ago already, and I am currently working at Maisonneuve-Rosemont in Montreal, affiliated with University of Montreal as an assistant clinical professor. Our co-validators tonight for this program are Lana Castellucci and Peter Gross. I will let them introduce themselves.
Good evening, everybody. I'm Lana Castellucci. I'm a thrombosis physician at the University of Ottawa, and I'm also a general internist looking after patients on the medical COVID wards.
And I'm Peter Gross. I'm a thrombosis physician at McMaster University in Hamilton. Enjoy the session.
Thank you very much. So tonight's learning objectives are to incorporate the latest information about thrombosis and COVID-19 into your clinical practice, to safely and effectively manage thrombosis for patients hospitalized with COVID, to discuss the hematologic coagulopathic issues around COVID-19, and finally to diagnose, rule out, and manage vaccine-induced immune thrombotic thrombocytopenia, or VITT. Here are our three main presenter disclosures. This program is supported by educational grants from Bayer, BMF Pfizer, Canadian Alliance, Leo Pharma, and Pfizer Hospital. I have to say that to mitigate potential bias, the agenda and faculty for this program was developed by Scientific Steering Committee from Thrombosis Canada. All faculty have been directed that any recommendations involving clinical medicine are to be based on evidence that is accepted within the profession. And all scientific research referred to, reported, or used in the CME-CPD activity in support or justification of patient care recommendations conforms to the generally accepted standards. Just before we begin, the system has automatically muted all participants except for the speakers. If you have questions, please use the chat function of Zoom, and one of the facilitators will ask it for you. We will take questions at 2 different times during the presentation. The first one will be after Dr. Tagalakis and Dr. Zarychanski presentation, and the second one will be after Dr. Pai's presentation at the end. Just to begin, a little reminder that SARS-CoV-2 has struck not only the world, but also Canada, with 1.18 million people infected up to recently. There are still above 7,000 new cases per day. There are more than 24,000 deaths in Canada, and only 30% of our people are vaccinated up to now, or had at least 1 dose of any of the vaccines available. Ontario and Quebec has been struck hard at first, Quebec, then Ontario, and now Saskatchewan is also getting up in cases and hospitalizations. Ontario are still at almost 4,000 new cases per day up to today, and Quebec is going a little bit down with 700 cases per day. The pathogenesis begins to be more and more known with advancing evidence and research. SARS-CoV-2 is, as you know, an RNA virus. It uses ACE2 receptor to infect hosts. Of course, ACE2 receptor is present in the lungs, but it also present in many other organs, including heart, kidneys, intestines, and endothelial cells. Diffuse endothelial inflammation, or endothelitis, seems to be a very important part of COVID-19 symptoms and disease, because it can be done either by direct viral infection, and also it recruits immune cells that produce a lot of pro-inflammatory cytokines and chemokines, as we can see on the image that you see that is a bit busy at the right of your screen. But I think it presents well that there is a leakage of all the inflammatory cells and cytokines that can result to widespread endothelial dysfunction, disrupted membranes, vascular thrombosis, microangiopathy, and even apoptosis. And depending on that inflammatory response, patients can be either very sick or has a mild disease. Recently, with pathology exercises that has been done on patients infected by COVID-19, we also saw that maybe one of the distinct features of COVID-19 is the ability to do angiogenesis that would even more recruit immune cells on site of infection. Now, if we go with the thrombosis risk, a lot of studies have been published on that since the beginning of COVID-19, first in Asia, then in Europe, and in North America. At the first reports and early data showed a bit higher thrombosis risk in ICU patients. That would go up to 15 to 30% of patients with COVID-19 in ICU having venous thromboembolism, and that was despite efficient thromboprophylaxis. Most of the VTE in ICU are pulmonary embolism. I should say that more recent data, including some North American ones, showed much lower dose of venous thromboembolism, going to 3.5 to 7% in ICU with thromboprophylaxis. We know that the thrombosis risk is dependent on the intensity of the disease, with ICU patients having a higher risk than wards patient, and wards patient having a higher risk than outpatients. Ward patients would have a 3 to 7% risk of thrombosis despite thromboprophylaxis. And then we saw pulmonary embolism, but also deep vein thrombosis diagnosed on the wards. Outpatients would not have a very high risk of thrombosis, going around 1.8 cases per 1,000 people tested for COVID-19. So that rate was not superior to VTE in patients that were tested negative for COVID-19. We do see in some studies a small increased risk in acute ischemic stroke. That risk seems to be quite small compared to venous thromboembolism, and depending on the studies, it goes from 1 to 1.4% of hospitalized patients with COVID-19 that would have had an acute ischemic stroke concomitantly. That said, the VTE risk is variable regarding to the countries that published the studies, but also on the type of studies, if it was cohort or randomized controlled trial. There seems to be a differences in the risk of VTE that was diagnosed. But now I would like to present our first presenter, Dr. Vicky Tagalakis, and I will let her take control of the screen. Dr. Tagalakis is an associate professor of medicine at McGill University in Montreal and is an attending in the Department of Medicine of Jewish General Hospital. She is the director of the Division of General Internal Medicine at McGill University. She completed an MSc in epidemiology and biostatistics at McGill University in 2003 and is a research scientist in the Center of Epidemiology and Community of Studies, Lady Davis Institute for Medical Research, Jewish General Hospital. She holds several peer-reviewed grants. She is co-lead of the Quality Improvement Platform of CanVector, a CIHR-funded national research network on venous thromboembolism. Dr. Tagalakis' principal research interests focus primarily on etiologic mechanisms for VTE and VTE outcomes, primarily in cancer patients. She has expertise in research methodology, including pharmacoepidemiology pertaining to thrombosis-related analysis of large administrative databases. She has been awarded numerous peer-reviewed research grants from national and provincial funding agencies and has published extensively in the field of venous thrombosis. Thank you, Dr. Tagalakis.
Thank you, Dr. Arsenault, for that very kind introduction. It's a pleasure to be invited here tonight, this evening, to discuss the issue of thrombosis, and in particular thromboprophylaxis in critically ill patients who are affected with COVID-19. So I will begin this evening's my presentation with a case. I'll just, excuse me. Okay. So here we have Mr. D, who's 68 years old. He presented to the emergency room with 3 days of increasing dyspnea. 8 days earlier, he had tested positive for COVID infection, SARS-CoV-1 infection. His past medical history includes diabetes mellitus type 2, hypertension, obstructive sleep apnea. His medications include, as you see there, metformin, valsartan and Norvasc for his hypertension, as well as Pantaloc, and he's on occasional alcohol use. Upon presentation to the emergency room, we note that he is quite, he desaturates and requires high flow of oxygen, 8 liters of nasal prongs. ICU has been consulted, and he is admitted to the intensive care for high flow nasal cannula oxygen. Decadron is instituted, tocilizumab as well. Given that there are no indicators of bacterial infection, in particular procalcitonin is normal, no antibiotics are started. I'll just sort of also relay a little bit of the progress here in this patient, because we will come back to this at the end with some of my questions regarding this case. On day 3 in the ICU, the patient, Mr. D, does deteriorate. A decision is made for intubation and sedation, and due to refractory hypoxemia, prone positioning and paralysis is started, as well as there's an increase in his steroid dosing with a more prolonged course. So my first question to the audience is divided in 2 parts. Question 1A is, upon admission to the ICU, which thromboprophylaxis regimen should be prescribed? A, low molecular weight heparin standard prophylaxis dose, and there are some dosing regimens for some of the more commonly used agents noted there. Low molecular weight heparin weight adjusted therapeutic dose, or low molecular weight heparin intermediate dose. And for example, for enoxaparin, this would probably or most often be 30 milligrams subcutaneous twice a day, or dalteparin 7,500 units once a day. And my second part to this question has to do when at day 3 this patient does, we know it does deteriorate, do we modify our chosen thromboprophylaxis regimen that we initiated at the start? So as I move forward, I want to discuss briefly and summarize essentially what Dr. Arsenault just walked us through, is that there is strong evidence after 1.5 years of data coming out of both in vitro tissue studies as well as observational studies, that there is evidence in support for thrombosis and COVID-19 infection. And this evidence is along the following spheres. Initially, we did note that excessive coagulation markers were noted in these patients with marked D-dimer elevation, as well as fibrinogen levels were noted. Moreover, on tissue studies and autopsy studies, there was extensive microthrombi seen, especially in the critically ill patients in the lung. And as Dr. Arsenault alluded to earlier, the term of pulmonary vascular endotheliitis has been coined regarding the type of disease that we see in these patients. Macrothrombosis in patients has also been extensively reported in several observational studies to date. And as Dr. Arsenault noted earlier, the initial reports listed rates that were quite elevated. And we see here, I'll present in the next two slides, two systematic reviews and meta-analysis, the first being by Melas and colleagues that was published in November of last year, that looked at all these observational studies and noted that there was a high risk of thrombosis, in particular in the ICU patient population of up to 31%, with 5% in the non-ICU patient population. And when we talk about a high rate of thrombosis, this is in particular specific to venous thromboembolism. Now, as noted by Dr. Arsenault, these were studies where the definition of venous thromboembolism varied. Moreover, the diagnosis was based on various different strategies, including symptomatic presentation versus surveillance with, for example, serial Dopplers in the ICU. The authors also looked at death or mortality associated with thrombosis, and they noted that amongst patients with thrombotic episodes, a summative rate of up to 23% versus 19% mortality in those without thrombosis. And when they did a comparative analysis, they noted that thromboembolism significantly increased the odds of mortality by as high as 74%. A more recent meta-analysis by Dr. Jimenez and colleagues that was published in Chest 2 months ago really documented the same sort of conclusion with a thrombosis incidence amongst 31 studies of 27.9%, despite use of at a minimum standard dose of anticoagulation or thromboprophylaxis in these patients. So it then behooves us to ask, is there a role, given this, based on these observational studies, tissue studies, autopsy studies showing these microthrombi and macrothrombosis, is there a role for escalated standard dose thromboprophylaxis in ICU patients? And the role being that, can it potentially decrease formation of these thrombotic pathology, whether at the macro or micro level, sorry, there was just a problem. Yeah, and even dampen the effect of the systemic inflammation on the coagulation cascade and vice versa. As we know, there's an intricate relationship between inflammation and thrombosis or coagulation, as Marie-Pier alluded to earlier in her presentation. And moreover, the ultimate sort of endpoint would be, can escalating our dosing of thromboprophylaxis impact on mortality in these patients? So I will be presenting to you a trial that was just published, I'd say about a month and a half to 2 months ago, that looked at this very question and looked at the use of escalation of a low molecular weight heparin or heparin-based thromboprophylaxis, comparing standard dose versus intermediate dose. And this is the Inspiration trial that was published in JAMA mid-March, March 18 to be exact. And my colleague, Dr. Zarychanski, who will follow after me, will be presenting some preliminary data coming from a combined multi-platform randomized clinical trial that looks at escalating further the thromboprophylaxis dosing to a therapeutic level and comparing this to standard dose. So let's focus on the INSPIRATION trial. Before I describe this trial, we should agree that we should have a definition of what critically ill means. And the definition is as such: patients with COVID-19 related critical illness are defined as those suffering from an immediately life-threatening condition who would typically be admitted to an intensive care unit. And so that for the admission would require, the requirement would be for hemodynamic support in an ICU setting, ventilatory support in an ICU setting, or renal replacement therapy in the ICU setting. So the INSPIRATION trial, its design was an open label randomized clinical trial, 10 centers in Tehran, Iran, specifically in 2 cities, Tehran and Tabriz. Enrollment occurred between July and November 2020. It was a 2x2 factorial design. As mentioned in my previous slide, it compared intermediate dose versus standard dose thromboprophylaxis or prophylactic anticoagulation, as well as statin therapy versus matching placebo. The results pertaining or analysis pertaining to the statin arm have not been yet made available or published, so we will be focusing solely on the thromboprophylaxis intervention. And once again, these were patients admitted to the ICU with COVID-19 confirmed disease within 7 days of hospitalization. So some of the exclusion criteria are here. Life expectancy of less than 24 hours was a criteria. And so they wanted patients who physicians felt would survive at least 24 hours or longer. An established indication for therapeutic anticoagulation, such as atrial fibrillation, was an exclusion criteria. Pregnancy, history of heparin-induced thrombocytopenia, weight less than 40 kilos, platelets less than 50, and evidence of overt bleeding. And so the interventions that were studied were specifically having to do with the low molecular weight heparin molecule enoxaparin. And the intermediate arm, enoxaparin, was given at a dose of 1 milligram per kilo sub-Q once a day. In the standard arm, enoxaparin was given at 40 milligrams sub-Q once a day. There were predetermined changes in the dosing according to weight. So if the weight was greater than 120 kilos or a BMI of greater than 35 kilos per meter squared, then in the intermediate arm, enoxaparin would be given at 0.6 milligrams per kilo twice a day. So that becomes a twice a day dosing. And similarly, in the standard arm, it also becomes twice a day dosing at 40 milligrams BID subcutaneously. So doubling of the dose in the standard arm. And assigned treatment was for 30 days, irrespective of hospital discharge status. So the primary efficacy for this study was a composite of adjudicated venous thromboembolism, arterial thrombosis, ECMO, or all-cause mortality within 30 days of enrollment. Secondary efficacy was all-cause mortality, adjudicated VITT, and ventilator-free days. Safety was major bleeding defined by BARC type 3 or 5 and severe thrombocytopenia. There was also clinically relevant non-major bleeding, which was defined as any type of bleeding that did not qualify as a major bleed, but did warrant medical attention. So here is a busy slide, but it is table 1, which looks at the baseline characteristics of the patients. I should note that about 1,040 patients were approached for this study. 600 or so were eligible for the study, and in the end, 276 were assigned to the intermediate, randomized and assigned to the intermediate dose versus 286 to the standard dose. There were various baseline factors that are presented in table 1, and we note that they were for the most part well balanced except for smoking, which is bolded here in red. The median duration of receiving the assigned treatment intervention was similar in both groups and was around 20 days. And the authors note that 78.6% of patients received the assigned treatment for the full study duration. We look at the outcomes here, both primary, secondary, and exploratory outcomes within 30 days of enrollment. And I've brought to your attention the primary outcome, major bleeding and severe and I have also included severe thrombocytopenia, brought them out from this busy slide just to show that the primary outcome, and I remind everybody, this was an adjudicated acute venous thromboembolism, arterial thrombosis, ECMO, or all-cause mortality. This occurred in 45.7% of the intermediate dose thromboprophylaxis group versus 44.1% in the standard dose thromboprophylaxis, with an absolute difference of 1.5% with an extremely wide confidence interval going from -6.6 to 9.8%. Or as an odds ratio, the odds ratio was also non-significant at 1.06. So essentially, there was no difference between the two groups when looking at the primary outcome. And when we do look at the secondary outcomes, we note that most of these events, 45.7% and 44.1%, were due to mortality or death, with death occurring in 43.1% of patients on the intermediate dose and 40.9% of patients in the standard dose. Adjudicated venous thromboembolism was only 3.3% in the intermediate dose versus 3.5% in the standard dose. And hence here, as highlighted by Dr. Arsenault earlier, comparing the early observational studies versus what we see in this trial, we see a dramatic difference in the rates of venous thromboembolism. And there may be some reasons for these that we can explore later in the question period, but likely just the nature of the fact that this is a prospective study in a trial setting versus the other studies where there was a mixture of retrospective observational types of studies with different definitions of venous thromboembolism, and often including arterial events in those primary outcome reported incidence rates, probably plays a big role in the difference that we see here. We should note that major bleeding occurred in 2.5% of the intermediate dose versus 1.4% in the standard dose. And again, this was not clinically different between the two groups. And what was different was severe thrombocytopenia. And by severe thrombocytopenia, we mean less than 20. This occurred in 6%, in 6 patients versus 0 patients in the standard dose thromboprophylaxis. And here we have the probability curves for the primary outcome, which again shows with a hazard ratio reporting of 1.06, essentially no difference between the standard and intermediate dose enoxaparin arms. Not shown here, but just to inform everyone, the per protocol analysis and other sensitivity analysis were very similar to these primary analyses. Moreover, there was no benefit of intermediate thromboprophylaxis in any of the pre-specified groups, and the authors do report that there was no interaction between the anticoagulant intensity and statin use in this study. So the conclusions from this trial were that there was no benefit to intermediate dose thromboprophylaxis in the primary composite outcome of venous or arterial thrombosis, ECMO, or death within 30 days. I want to just highlight to everyone once again that the risk of VT was much lower than what was being primarily reported by many of the observational studies early on in the pandemic, although as Dr. Arsenault noted, more recent prospective registry studies out of the US do point to a much lower rate of thrombosis and probably more similar to what we're seeing here. Important limitations need to be highlighted. This was a study exclusively done in Iran. External validation is an issue, and the generalizability, therefore, is an issue. Standard dose thromboprophylaxis essentially was doubled in patients who weighed more than 120 kilos. Although when we look in the supplement, that seemed to be in only 10 patients in the whole trial, so it's unlikely to have a significant impact. Moreover, these patients on admission to the ICU, 43% were receiving high flow oxygen support. They did not require intubation at that time. And so one wonders about the acuity of these patients. And it would be interesting to hear from other studies and moreover, studies that Dr. Zarychanski will be presenting earlier to compare the acuity of those patients that were admitted in the ATTACK study. And obviously, therapeutic dose low molecular weight heparin was not investigated in this trial, but was investigated in what we'll be hearing soon from Dr. Zarychanski in the ATTACK trial. So if we go back to, I'll end with back to our case here. So if you had to choose based on the INSPIRATION trial, which thromboprophylaxis regimen we would be prescribing to this patient, I think given the data we have so far, and this obviously is fast-paced and changing very quickly, we would be prescribing standard dose thromboprophylaxis. Clearly INSPIRATION, although there may be issues with power, given that the confidence interval was quite wide, as I mentioned earlier, but at least with the study results, the suggestion is that intermediate dose would not be helpful here. I asked question 1B, at day 3, the patient deteriorates. Do you modify your thromboprophylaxis regimen? I put this though here because there is no evidence to modify your thromboprophylaxis, but I want to make this audience very attuned to the fact that any deterioration in respiratory status should prompt one to investigate for thrombosis. And specifically for pulmonary embolism, because indeed, if a diagnosis of PE is made, then there would have to be escalation of anticoagulation in that case. I'll just provide you some guidance from the American Society of Hematology. They were recently updated April 7, 2021, and likely to be updated soon again. But initially, the American Society of Hematology was recommending suggesting using prophylactic intensity over intermediate intensity or therapeutic intensity anticoagulation for patients with coronavirus disease related critical illness who do not have suspected or confirmed venous thromboembolism. This was the initial sort of recommendation or suggestion. Since publishing of the INSPIRATION trial, a split has been made. The decision was made to split their recommendation, a recommendation 1A and a recommendation 1B. The recommendation 1A, based mostly on the INSPIRATION trial, now suggests using prophylactic intensity over intermediate intensity anticoagulation for these patients. And we are awaiting a recommendation B that will address therapeutic intensity versus prophylactic intensity anticoagulation is anticipated soon. This is my final slide. This slide I've put up is a bit busy, but it's a great pictogram that shows the clinical stages of COVID-19. It's from the Lancet Hematology, a couple of weeks ago was published. And only to highlight to the audience that there are ongoing studies that are addressing thromboprophylaxis in the various stages of COVID-19 infection. I just described to you the INSPIRATION trial that looked at the ICU environment where patients are admitted to the ICU. But there are studies that have been completed and we will be hearing about soon that have looked at ongoing ICU, that have looked also at critically ill patients as well as hospitalized patients. And from the same multi-platform randomized clinical trials, we do have studies that are addressing the use of thromboprophylaxis in patients following hospital discharge, and as well as patients from other studies that are looking at the use of thromboprophylaxis in the ambulatory setting. So there is quite a bit of research and studies ongoing in this area and addressing the various phases of our disease. And I'll turn over now to Dr. Zarychanski, who will follow up on his work that's been done in the critically ill patient population, as well as the moderately ill hospitalized patient population. Thank you very much.
Thank you, Dr. Tagalakis. I will now introduce our second speaker, Dr. Ryan Zarychanski. Dr. Zarychanski is a hematologist, critical care physician, and clinician scientist at the University of Manitoba and Cancer Care Manitoba. His research focuses on the hematologic aspects of critical illness, where he leads several national and international randomized trials in the fields of sepsis and transfusion medicine. Dr. Zarychanski is the chair of the COVID-19 clinical trials team in Manitoba and serves as the chair for 2 international trials evaluating anticoagulation strategies in COVID-19 and sepsis. Dr. Zarychanski.
Hi there. Thank you very much for that introduction. And thanks for the invitation to speak here amongst many great invited speakers. I'm going to talk a little bit about anticoagulation trials that I am familiar with and following on the footsteps of the presentation you just heard. And so I'm going to really focus on a multi-platform trial that I had a role in leading that forwarded some of the data that evaluated a hypothesis of thrombosis, which we thought was prominent at the beginning of the pandemic, which may be less so now. But what was really important is this concept of D-dimer. And we recognize that, okay, even if everyone's not at risk for thrombosis, some people appear to be, some people are. And can we use D-dimer to help stratify, or could we identify those people at higher risk? Number one, that's sort of prognostic enrichment. And can we then, if we identify a group, can we treat them differently because they have a different D-dimer? And we don't know this at all. It was really suggested early in the pandemic that we measure D-dimer in everyone like it's somehow a novel biomarker in sick people. But then we didn't know what to do with the information, which I always thought was a little bit odd with the recommendation. And then there was these observational studies, some of which were alluded to, and I just picked one because I particularly find it unfortunate because it really highlights the issue of confounding by indication and survivor bias, where observational studies showed benefit, and because people often survive to get anticoagulation and it was indicated for whatever cause. So we really needed randomized trials to help move the data, move the field forward. And we hypothesized that if we provided therapeutic anticoagulation to hospitalized patients, that we might improve their outcomes irrespective of thrombosis. And we were really interested in the idea of anticoagulation, particularly with heparin being an anti-inflammatory agent and an anti-thrombotic agent, obviously. Sort of this idea of thromboinflammation that you heard about in the introduction to today. And so to help answer this question, we formed something called a multi-platform trial. And the multi-platform trial is a collaboration of 3 independent platforms. And so you'll hear a lot about platforms in the next few years because the idea, the concept, and the operation of platform trials really came to fruition, I think, in a really large way in COVID and clinical trials of COVID. And so there was a platform trial that I started with my colleagues, Ewan Gallagher and Patrick Lawler and others, called ATTACK, where we were evaluating heparin, therapeutic dose heparin, in ward patients. So like we call them moderately ill patients. They're on the ward, not on organ support or not ICU-like patients. And then we had also started, myself and a colleague started a domain within a platform trial called REMAP. That's not important what it stands for, but it was a embedded domain evaluating therapeutic dose heparin in critical care of COVID. So ATTACK was on the ward and REMAP was in the ICU. And then the NIH came knocking at our door and really wanted, they were kind of charged with developing a platform trial for the United States, funded by the White House. And they essentially adopted the protocols that we started in TAP and REMAP. We collaborated and we made small changes along the way to make everyone happy. And we really were a combination of 3 independent platforms, all with one harmonized trial protocol on the ward and in the ICU. And so what a great concept for a global collaboration. So 3 independent but collaborative platforms now with a harmonized protocol, common primary outcome and secondary outcomes and safety outcomes, all working together to quickly answer this question of therapeutic dose anticoagulation in moderately ill, that's ward-based patients, and severely ill patients in the ICU. So who do we study? So we studied adult hospitalized patients, and there are some like small nuances. I can answer any nuance you want, but I'm just trying to distill it down to a message as well. And so the patients were hospitalized for COVID, so they had respiratory signs and symptoms of COVID, and they had to be enrolled within 72 hours of admission or test positivity. It's not and but or. The exclusion for REMAP in the ICU was 48 hours, and on the ward actually it was up to 14 days for that platform. So there's a small difference in that platform. The exclusion criteria are varied, but they really come down to like you weren't at high risk of bleeding, or you didn't have a contraindication or you didn't have an indication for a therapeutic anticoagulation already. And so they were actioned different ways, but those are essentially the exclusion criteria. And dual antiplatelets was a common exclusion criteria as well, I might add. And so the intervention was therapeutic dose, low molecular heparin or unfractionated heparin, however you gave it to treat VTE in your center. And the control was usual care pharmacologic prophylaxis, however you gave it as well. And it wasn't like protocolized because there was this shifting concepts of appropriate pharmacologic prophylaxis throughout the pandemic, where it started out as normal, like started as regular low-dose prophylaxis, and then there was panic, and then people said we have to give intermediate, and then some people bled in their heads, and then we said, okay, well, let's go back to what we normally do. But UK decided to still use their intermediate dose and defined it 36 different ways. And so there was some different pharmacologic prophylactic strategies for sure. And so we just studied usual care. And the duration was up to 14 days of hospitalization or until liberation from supplemental oxygen in one of the platforms, whichever came first, or discharge from hospital. And so the platforms were like 96% homologous and 100% in the most important ways. The primary outcome was an outcome called organ support-free days. And organ support-free days, I just want to spend a bit of time on this so everyone understands it. It's not as hard as it sounds, but it's definitely a new kind of description of an outcome. And so it's an ordinal scale, so it's not continuous, although everyone wants to make it that way. And so it's ordinal scale that ranges from dying, and you get a -1 to 21, where and 21 really means no organ support at all. So that means you stayed on the ward. You didn't need ICU level of care. And anything in between is the amount of days that you were free of organ support. So if you were ventilated for 15 days, you would get a 6. Okay, because you had 6 ventilator-free days or organ support-free days in that case. Or I use ventilation as an example, but organ support could have been non-invasive, high flow in a small portion of patients, ECMO or pressors, not renal replacement therapy, by the way. And that mimics other support measures anyway. And so this is a very important outcome because it's something that can be used in the ICU where it really measures the days of organ support, and it can be used on the ward where it really functionally measures, do you go to the ICU or do you get to need organ support wherever you receive it? I hope that's clear. This secondary outcomes were like safety, major hemorrhage and HIT, as you could imagine, and efficacy measures that are all predictable and not that interesting, but important. Mortality, intubated, not just organ support, but intubation, major thrombosis, hospital length of stay, things like that. I talked that it's an ordinal endpoint, organ support free days, that includes mortality. It's calculated as a cumulative using a cumulative logistic proportional odds model because it is ordinal. It's controlled for site, for time, because our treatments change over time, and the people getting admitted to hospital change over time even, and controlled for sex and age as well. A shifting pandemic, probably many more RCTs control for these kind of variables that could change over time as well. Ours did. It's a Bayesian trial, and I won't get into that too much in this presentation, but suffice to say we had no preconceived notions of whether heparin would work or not. So those are called neutral priors. And we incorporated something called dynamic borrowing, where like or very similar information amongst severity groups or D-dimer groups could be used so that the trial could be stopped as quickly as possible by improving the power, or really the precision within a certain subgroup, and it allows us to moderate the treatment effects so they're not extreme too. So it averages them to the green or regresses them a little bit to the mean, because if you stop a trial early, you can have extreme values that aren't replicated at the end of the trial. Okay, and it's so interpreting the proportional odds model of the ordinal scale is, so red is death, so red is dead, and so and that is a -1, and dark blue is 21, and those are people who never were on organ support, and the odds ratio is calculated by the value in this case of death compared to anyone who survived. So that would be anyone who gets 0 or higher, to be honest. And then the next group is calculated to 0 or death and 0 compared to everyone else. So it's calculated ordinally along the way at different aspects of the scale. And that's how you get an odds ratio. And you compare the probability of a pre-intervention compared to one post-intervention, and the difference would be the probability of that would be the difference in the probability of some event occurring, in this case organ support free days, between the prior and the posterior probability. Okay, we calculated this as for severe critical ill patients, and within the moderate group, we were really interested. Our a priori stopping criteria were split between a high D-dimer that's greater than 2 times upper limit normal, and a low D-dimer, which is less than that. Because we wanted to know what the hypothesis was, does D-dimer make a difference? We wanted to test that. We stopped the trial if we were 99% certain that the therapeutic heparin was better than control, and we stopped if there was a low chance that there was what we thought was a clinically relevant difference. And we could stop separately for each D-dimer stratum. Okay, that just tells you a little bit about the platforms, some leadership, some funders, different countries, different sites, different statistical coordinating centers and data coordinating centers. But all the data, this is not a meta-analysis, all the data line item, like line patient data, is fed all through each of the platforms to one statistical group in the United States. Okay, we stopped the moderate state on block, that means for both D-dimer strata, that is the high D-dimer and the low D-dimer, for superiority. So therapeutic dose heparin was better than usual care in January, and 1 month prior to that, we stopped the severe group for futility, where therapeutic heparin was not better than usual care. And in fact, there was a high probability it was inferior to usual care. These papers, the severe is submitted for publication and is on a preprint server. It's very close to being in the finalizing, the review stage being finalized, and the moderate state paper is written as well, and it's and so I can't share everything in its sort of publication format, and so I'm going to show some of the results that are in a different format, very mature data that is in line with the adaptive, or another way of saying that is interim, but the adaptive results that are prior to final publication. And so the final group enrolled, there was 2,231 patients randomized to the moderate group, over 1,000 in severe. There's a few outcomes that we couldn't account for with patient transfers. So the final patient group is just about over 2,200 in moderate, and just over 1,000 or almost 1,100 in severe. I could answer any questions about baseline characteristics. I'm looking at them now on a different screen. They're balanced. They're a large randomized trial. The average age was around 60. Apache score was around 13. 3/4 were invasively or non-invasively intubated in severe, or invasively or non-mechanically ventilated in severe. The D-dimer, which is a little bit of a non-perfect measure because of different assays, but the median D-dimer was around 800 in severe, 600-ish in moderate. I could answer any other questions that people have, but I just want to say that the outcome of organ support-free days functions differently according to the severity state. So in severe at the bottom, it functions as sort of either you're dead here, this is -1, or the days of receiving organ support. But in moderate, it really functions, you can see, in a binomial way, where either you die or you don't ever require organ support. And it's actually a combination of 21 and 22, just measured differently in the platforms. So it functions a little bit differently. That is, you don't require organ support, or you do in moderate. So the extension is, can you prevent critical illness or the need for organ support? And in strained hospital systems, that's really important, especially when it incorporates death into the outcome. And so this is the near final results of the multi-platform RCT, where we published this in their sort of in public release at the adaptive results, and they've been updated along the way. And you'll have to wait a little bit for the very final published results, but these are essentially where they are going to land. Where in severe illness, heparin doesn't make a difference. These are proportional odds ratios, and a lower odds ratio is more mortality and less organ support-free days, and higher odds ratios are more survival and more organ support-free days. And so in any of the D-dimer groups, low, high, or missing, or that really is unknown because it wasn't measured, heparin has an advantage where it increases survival and organ support-free days. And remember, it functions a bit as a dichotomous there, so that by extension really means it prevents progression of critical illness. And in the severe, or the group with organ support at baseline, defined, as I said, with high flow, non-invasive, invasive, or ECMO or pressors at baseline. If you start therapeutic dose heparin at that time, there's no advantage. And in fact, there's a high probability of inferiority where therapeutic dose heparin is worse. And likewise, in the all moderate group or in any other of the D-dimer groups, there's a high probability, like 99% posterior probability of superiority. This is the horizontal heat map plot, which I won't go more into right now, but suffice to say there is more red, so there's more people who died in the severe group, less people who died in therapeutic anticoagulation in the groups. Not evident in this top one because it's not adjusted for age, sex, time, site, or the statistical borrowing. But there's an advantage that's consistent amongst all groups as seen by the odds ratios here. Mortality on its own was in the right direction for moderate and in the wrong direction for severe, with mortality, with posterior probabilities that weren't quite as high because the groups were smaller just for mortality, because mortality is relatively not rare, but it's only like 5% of patients or so in moderate, where it's like 40% of patients or 36% of patients actually in severe. I think that I'm not going to present the data for the rest of the moderate results on the screen because they're still under review and that, but I will say that there's an absolute difference in survival and survival to hospital discharge without needing organ support. And so that, as again, organ support functions dichotomously. So you can prevent about 4.6% of patients from ever needing ICU level care or surviving, that is survival or ICU level care with therapeutic dose heparin compared to usual care. And likewise, those are important improvements in survival without intubation specifically. So not even organ support, but specifically intubation, survival without hemorrhage, survival without thrombosis, and survival to hospital discharge. Major bleeding was low. And so there was I think about 1,080 patients in the therapeutic heparin group, 1,046 or 50 in usual care here, and about 500-ish in each of the group in severe. And yes, there is a higher hemorrhage rate or major hemorrhage rate in therapeutic dose heparin, but they're low, right? Overall, right? 1.6 compared to 0.9. Likewise, even in the ICU, 3.6 compared to 2.4, which I think are rates consistent with in the severe state with inspiration, as I recall as well. And this is major thrombotic events or death. There was no difference in major thrombotic events or death in severe state, and a 2% reduction in major thrombotic events or death in the moderate state. Thrombosis in itself was a low event, like 2.5% or so in moderate in the control group, and just under about 1.7% or so for those who are interested in moderate. So low doses of thrombosis, low event rates of major thrombosis and death, 8 versus 10%-ish. So the conclusion in moderate state is that in hospitalized patients not receiving ICU level organ support, therapeutic dose anticoagulation increases the probability of survival to hospital discharge with reduced need for critical care or ICU level care organ support. Results that are improvements in more morbidity through organ support and mortality, which are components of the primary endpoint. Low rates of bleeding, and again, treatment effects modest in the low D-dimer. I shouldn't have said it that way. I should say that the absolute difference is lower in low D-dimer patients because the event rates are lower, but the relative rates are actually quite consistent across the D-dimer spectrum. And in severe patients, that is those receiving ICU level care or organ support at baseline, which I've defined several times already, but I can again in the question period. Therapeutic dose heparin does not improve organ support-free days. In fact, it's high probability of inferior, and I wouldn't use it in that patient population. The preprint for severe is online, and the publication should be coming soon. I don't control all aspects of that. A question that comes up a lot is what to do with people who transition from moderate to severe or get started on therapeutic dose heparin on the ward and go to the ICU, because those patients did worse in the ICU. Like, should we stop it? And the answer is we have no idea. And I will say that the data that I presented that showed therapeutic dose heparin in moderately ill patients, those not on organ support at baseline, the data that I showed that therapeutic heparin is beneficial included a protocol that continued the therapeutic dose heparin if patients transition to the severe state. And that's the trial that concluded and will be published as beneficial. And so will your patient derive more benefit if you stop therapeutic anticoagulation when they go to the ICU? I don't know, maybe. Will they derive less benefit if you stop it? Maybe. And so I think that there's a legitimate uncertainty on how to manage those patients. And I might suggest in those patients, you do what you normally do in the ICU, whether that's intermediate dose or whatever you do. And there's no wrong answer, because it's a question that now needs to be answered with randomized trials. I just wanted to thank, there's a lot of funders in this and partners. CanVector is really an important integral partner to the success of this study, who are part of the protocol development, adjudication of outcomes, patient partners, etc. And it's been an incredibly productive partnership with thrombosis experts in Canada, and others listed on this screen here. Thank you very much, and I'm happy to answer questions. Publications for both of these are pending, so consider these interim. They're getting very mature, but I wouldn't I'd wait again to see the final results before disseminating them publicly to others.
All right. Thank you, Ryan. Dr. Castellucci and I will share picking some of the questions for you and Dr. Tagalakis from the chat group. So a common question is the high flow nasal cannula. So that was included as being you were allowed to be on that for moderate state, or you weren't. And then if you progress to high flow nasal cannulas, was that an outcome, and how much flow?
Yeah, right. So high flow nasal oxygen was counted as severe in the majority of the patients. Only 2% of moderate patients were on high flow nasal oxygen on the ward. And that was one of the small differences about REMAP, one of the platforms where that also required you to be in an ICU. So for the majority, the vast majority of moderate state patients, high flow nasal cannula was not, would have put you as a severe, in a severe group from the beginning.
Okay. And then there were two questions about heparin or low liquid heparin. Do you have any data on how many people received what? Yeah,
so the majority, like over 80%, received low molecular weight heparin.
Okay.
The protocol adherence in the moderate group was about 88%, I think, on the first day as we defined it, and in the therapeutic group, and like close to 100% in the prophylactic arm.
And the duration. So if someone is on it, put on the therapeutic heparin, how long do they stay on it for?
They stay on it as per protocol until hospital discharge, or up to 14 days. The median duration of hospital length of stay was about 5 days in the moderate group, and I can't remember offhand what it was for the severe group, but it would be a lot longer than that.
Okay. Dr. Castellucci, do you want to pick a question?
Yes, thanks. Vicky, maybe if you could tell us in relation to your case that you presented, how would you transition your patient? Would you make a change in anticoagulation regimen in your patient who deteriorated and required transfer? How would you handle that with the information you have today?
Well, as I alluded to in the case, so this was a patient who was admitted to the ICU and was put on prophylactic dose anticoagulation. Upon deterioration, truthfully, these patients, all sorts of things have been done over this past year in the pandemic. Patients upon deterioration would be escalated to intermediate or therapeutic without investigation early on in the pandemic for the fear of preventing COVID infection in hospital workers and isolating patients from that. And so diagnostic imaging would not have been done. But of late, given preprint results that we're hearing from the multi-platform trial, in a critically ill patient population, we wouldn't necessarily escalate based on deterioration. But as I alluded to, we would consider escalating if there is a diagnosis of pulmonary embolism, for example, in this patient. And that's the message here, is that deterioration can often mean that there is a thrombotic event occurring, and the message is that we should escalate if we make that diagnosis.
All right.
There was a question that said that, could I ask a question, if you don't mind? That asked, the slides move quickly, but it appears to be the mortality was not significant. Could I speak to those numbers? And yes. I apologize if I went quickly, but it is pre-publication, but very close to publication. So I really was hoping to avoid people quoting me in public fora about it as well. But I want to also remind that this is a Bayesian trial, and so the word of significant or not significant isn't applicable. And so instead we talk about posterior probabilities. And so was there a high probability that heparin was, therapeutic dose heparin was beneficial in the moderate state group? Yes. How high? 99% high. And so if you can say, if you go to a patient and say, if I get this, what are the odds that I'll derive a benefit that is higher than if I did not receive usual care? You can say with 99% probability, you'll receive a benefit that is of in the right direction. And in this case, the absolute difference was about 4.5%. So what that means, again, Ontario, for instance, in a place where I could just provide a snapshot image where ICU space is non-existent in a sense, where at capacity, and 25% of people would require some level of ICU support if they're admitted to the hospital. That could be reduced to about 21%, in fact, 20.5%. And so if you can, out of 100 people, have 5 less people going to the ICU, that makes a big difference from a resource allocation perspective. And those people not only don't require ICU, but they also survive because it's a combination of the outcome. I hope that helps to clarify.
It does. Thank you very much. Thank you. Thank you for that. Dr. Arsenault, I think we need to move on for the sake of time to Dr. Pi.
Yes. So it is my pleasure to introduce our third and final speaker for this evening, Dr. Menaka Pai. Dr. Pai completed her medical training at McMaster University and at the University of Toronto. She has been a hematologist and thrombosis specialist at McMaster University since 2008. She is currently an associate professor in the Department of Medicine and head of service for benign hematology at Hamilton Health Sciences. And she's also a quality lead for transfusion medicine in the Hamilton Regional Laboratory Medicine Program. Dr. Pai holds a master's degree in health research methodology. She is a member of McMaster University's Thrombosis and Atherosclerosis Research Institute, and also of the McMaster Center for Transfusion Research. Her research interests include venous thromboembolism, research methods in rare diseases, clinical practice guideline development, and quality improvement. Dr. Pai?
Thank you so much, Marie-Pier. I'm really honored to be speaking to you all today about VITT following adenoviral vector COVID-19 vaccines. And I'm going to go through my slides a little quickly because I do want to leave time for questions. I have no current financial nor intellectual conflicts of interest to declare. Today, we're going to talk about vaccine-induced immune thrombotic thrombocytopenia, the suspected pathophysiology, rapid identification of the syndrome, as I expect many of you are really on the front lines of making this diagnosis. And then we'll talk about treatment. This is a newly described syndrome, lots of unanswered questions, so we will touch on that as well. I'm going to start with a case. Now, this is not a real patient, but this is a composite of many cases. We've already had 8 reported cases of VITT in this country and many hundreds of reported cases around the world. This is a 56-year-old woman who received her first dose of the AstraZeneca Covishield vaccine 12 days ago at her local pharmacy. She presents to her family physician today with a severe headache. It's gone on for 2 days. Nothing's helping. It's so bad that it makes her feel nauseous. And she's developed blurred vision and diplopia this morning. Her medical history is really very bland. Now, when she presents at the local emergency room, a routine CBC is done, presenting platelet count dramatically low at 31, and there's really no other abnormalities on the blood film. So this patient is obviously ill. Your question as a physician is what's going on, and does the vaccine she received have anything to do with it? So as I mentioned, VITT is a newly described syndrome, and there are some key features that I want you to remember. First, patients have blood clots. They are generally in unusual sites like the cerebral veins or the splanchnic circulation. However, there can also be more garden variety clots anywhere really in arterial or venous territories. Patients also have thrombocytopenia, usually quite significant. And the patient's actually generally healthy before presentation. Now, there's no signal of affected patients having anything specific in their medical history, and I'll talk about that more in the next slide. Despite their general good health, early reports stated a case fatality of 40%. Now, with the increased awareness and quicker diagnosis and treatment, we believe the case fatality is now around 19%. Now, the syndrome's onset is also very stereotyped. So symptoms start between 4 and 28 days following vaccination. And this time frame actually gives us some clues as to what's going on. So what you're seeing at right is not a diagram of VITT's pathophysiology. It's a diagram of an analogous condition called heparin-induced thrombocytopenia, or HIT. In HIT, some patients who receive heparin develop antibodies to a complex of heparin, which is a charged polyanion, and platelet factor IV. The PF4 is a small positively charged molecule that normally sits inside platelet granules. Now, these antibodies to that PF4 heparin complex, they stick to platelets and they activate them. So the end result is that you have platelets that are switched on. They're very prothrombotic. They start this coagulation storm, and then the platelet count falls because activated platelets are rapidly cleared, and you can get blood clots in venous or arterial territories. Now, in VITT, there is no heparin in the mix. These patients have not received it. However, we do see similar antibodies that have developed to platelet factor IV and some as yet unidentified polyanion. And the result, coagulation storm, activated and cleared platelets, detectable antibodies, is exactly the same. Now, the incidence of it has been really challenging to calculate. Right now, we believe the possible incidence is about 1 in 50,000 to 1 in 100,000 doses. And a lot of that depends on how we count vaccine adverse events. In Canada, because we gave the Covishield vaccine for a very defined period of time, we can actually tell you that the incidence is truly 1 in 50,000. It does appear that younger patients are predisposed to VITT. Perhaps there's a slight predominance of women. What I can tell you is that there are no clear risk factors. So things that you see here, whether it's previous clots, the use of hormones, having a platelet disorder, none of that seems to put patients at increased risk. So we really can't risk stratify who is susceptible. If your jurisdiction uses adenoviral vector COVID-19 vaccines, so that's AstraZeneca, Covishield, or the Johnson & Johnson vaccine, you need to be aware of VITT. You need to have some level of comfort diagnosing and managing it. And the algorithm that is on your screen right now is part of Thrombosis Canada's guidance, which is really uniquely tailored to the Canadian context. So we've tried to create something that really captures the clinical care of VITT right from patient presentation onto the point of treatment. Now, one note as we move forward, you've probably seen this syndrome called many different names, like VIPIT or TTS. I'm going to use VITT just because it's easy to say, but the terms are really quite interchangeable. Now, it's important to remember that VITT is a serious adverse event. So as I said, the reported case fatality can be as high as 40%. And now we have some experience with VITT in this country, and I can tell you that these clots are really aggressive. But the symptoms, they feel really maddeningly common. Because the syndrome itself is rare and the symptoms seem a little ubiquitous, it's important not just to rule VITT in, so you can quickly start life-saving treatment, but also to rule VITT out, because you want to make sure patients who don't have it don't get a lot of unnecessary diagnostics or treatments. We have to be very transparent about this adverse event and spot it when it comes up, but we also have to reassure patients and clinicians that not every headache after a vaccine needs aggressive workup. So that's why I like to sort of approach the problem in 3 stages. You start with a suspected VITT, a patient who's presenting to really any healthcare setting with some nonspecific symptoms. You can do a very straightforward workup at that time. If that workup is positive, you move the patient to a more acute care setting, like an emergency department, for advanced tests and imaging. And finally, if you have a presumptive diagnosis, you confirm it with specialized testing and you give empiric treatment. And I'm going to go through these things quickly. So the first step in working up VITT is to listen to the patient's story. Though the symptoms seem really non-specific, all of the reported cases follow a clear pattern. I have quite a laundry list here of symptoms, and you can find them all in Thrombosis Canada's guidance. But what's really important to remember is it's not just typical symptoms of arteriovenous clots, it's a typical time frame. The symptoms start 4 to 28 days post-vaccination. Now, once VITT is on your radar, what do you do to pursue the diagnosis? Well, again, focus on basic workup. Focus on things with a high negative predictive value. Now, the really key step, I feel, at this stage when you think something's going on is to draw a complete blood count. Now, this test, if it can be resulted quickly, you can do it in a family physician's office. But to move things along, you can certainly do this and get results often quicker in a setting like the ER. When you get your CBC results back, focus on the platelet count. So in all reported cases of VITT, that platelet count is between 10 and 110. So it is low. And the median count is about 20 to 30. Now, in diseases like HIT, we wonder about the patient's platelet drop from baseline. But of course, because these patients are healthy, we often don't have a baseline platelet count. So really just focus on the CBC and the platelet count in front of you. If your platelets are not decreased, this is sufficient to rule VITT out. You still have to work up the symptoms, of course, but a low platelet count, often an impressively low platelet count, that keeps the diagnosis in play, and it gives you that label of suspected VITT. And the next step is to focus on more advanced tests, including the D-dimer, the blood film, and appropriate imaging. Now, VITT appears to be associated with really strong systemic coagulation activation. So, as you're converting fibrinogen into fibrin and you're laying clots down and it gets broken up, you're going to see an elevation in the D-dimer, generally over 2,000, nearly always over 4,000. Now, our algorithm doesn't demand that additional coagulation testing is done, but if the fibrinogen is drawn, it will often be low. The PT and the PTT are generally decreased too. The blood film is important because of what it doesn't show. So in VITT, you should not see red cell fragmentation. You should not see platelet clumping. You should just see low platelets. Now, imaging is required to diagnose thrombosis. Generally, this is very important in this syndrome. I'm not going to review this in detail, but what I will remind people, because I think the trickiest clot of VITT is really the cerebral sinus vein thrombosis. I would encourage you to remember that a non-contrast CT head is actually not sensitive enough to rule out CSVT if you really are suspecting one. You can do an MR and MR venogram, or if that's hard to get in your center, it's hard to get in my center, you can do a plain CT and a CT venogram. So again, you have to sort of do both the plain imaging and also the venographic imaging. And finally, before I move to my next slide on testing, we do have a couple of reports of patients who have really demonstrable VITT with all of the confirmatory testing, but they don't have a blood clot. Now, these cases seem to be very rare. They might represent a pre-VITT syndrome, so it means you caught it before clotting has happened. If your clinical suspicion is high and you can't find a clot, then send off testing anyways, call a hematologist or thrombosis specialist, and consider treatment as a presumptive diagnosis of VITT. The important thing about this syndrome is not to be frightened, but really to keep your radar up. If you don't consider VITT, you will miss it. I'm not going to go into detail on testing, but I'm going to make a couple of comments, a couple of pearls that we've learned. The way to really test for VITT is to test for the analogous condition, to test for HIT. You want to find those antiplatelet factor 4 antibodies. We have learned through experience and through formal testing that an enzyme immunoassay is required to find these antibodies. Some of us around the country are using rapid assays for HIT that use different antigenic targets, and they appear to yield false negative results. So it's really important when you test for antibodies with HIT antibody testing that you're using an ELISA. If you're not sure what assay your lab is running, that's okay, but it's important to give a call in to find out. And then finally, when you do find those antibodies, you want to do confirmatory testing with a serotonin release assay, a functional assay. But what we have learned is that IVIG, one of the treatments for HIT, actually inhibits this reaction. So make sure you draw your samples for testing before you treat. You don't have to wait for testing to come back. It can take a little while. You can treat empirically, but get those samples sent off. We are very lucky to have the National Reference Laboratory for Platelet Immunology at McMaster. They will do enzyme immunoassay testing, and they are the only center in Canada doing SRA testing, and grateful to our lab directors for really working fast and putting together a test requisition that can be accessible anywhere in this country. So in the algorithm I showed you, I kind of emphasized the role of hematology or thrombosis medicine consultation if you think you have a VITT case. So if you have those typical symptoms and the typical time frame and the typical labs, please phone a friend. We're here to guide you with testing. We're also here to guide you with treatment. Treatment is very similar to autoimmune HIT. We do not give heparin, and we do not give platelet transfusions. We believe they theoretically could add fuel to the fire and worsen thrombosis. We do choose first-line anticoagulation with non-heparin anticoagulants. Here in Ontario, we recommend direct oral factor Xa inhibitors like rivaroxaban, apixaban, or edoxaban if the patient's stable. That's because these are easy drugs to use and get. But certainly if the patient is unstable or has a renal impairment, you can consider parenteral anticoagulants. You can consider fondaparinux. You may want an expert to assist with that. And very key, IVIG 1 gram per kilogram daily for at least 2 days is what is really going to raise your platelet count, extinguish that clotting storm. And finally, I'll mention this is a reportable condition as a vaccine-associated adverse event, must be reported to public health and also the regulator. I don't have a lot of time left, but I will say that there's lots and lots of questions remaining. Thrombosis Canada has put together a really phenomenal guide as well as a tool that you can use at the point of care. The Ontario Science Table is also releasing evidence-based summaries and a suite of tools for different types of physicians in different settings. So we think that's going to come out in 24 hours. AstraZeneca has really seized the headlines, I think, and caused quite a lot of worry. And now Janssen is coming in soon as well. Physicians have really been flooded with questions from concerned Canadians, and we're concerned too. I will say that this story, it really celebrates the strength of global collaboration, of vaccine safety and surveillance. And it's really taught us that we need to give patients nuanced and honest information about vaccines. We're doing our part at Thrombosis Canada to make sure you're ready to detect and manage this rare and serious adverse event. And I am happy to take questions.
Many thanks for that, Menaka. That was a great presentation and a great summary. Some of the questions that have come through are related to degree of thrombocytopenia with VITT, and if you could perhaps comment on that.
Yeah, that's a great question. So, again, we're all sort of basing this on case reports. This disease didn't exist a month and a half ago. But what we found is that the range, again, all reported cases around the world, is between 10 and 110. Median platelet count is 20 to 30. So this is not a subtle thrombocytopenia. And I will say that the Canadian cases that we've been dealing with that really pronounced low platelets, we're talking like 10, 20, 30, and very strong coagulation activation with a high D-dimer.
Great, thank you. Some other questions that have come through are related to whether or not VITT has been seen with the mRNA vaccines, or if we're expecting any other similar complications.
Yeah, great question. So, I said we don't know what the cofactor is for the vaccine. Like, we don't know what the magic thing is that causes antibody production, but the adenoviral vector vaccines have a lot of polyanionic bits in them, and we think that's why they do it. There are no cases of VITT with mRNA vaccines, and the rate of thrombosis with those vaccines is not higher than the general population. We do not believe they would cause VITT, and importantly, the antibody is not against it doesn't involve the spike protein. So if you have VITT with AstraZeneca, you can safely get an mRNA vaccine, we believe, as your second dose.
Okay, thank you. That's helpful. Peter, I don't know if you have any.
Yeah, there were also a couple of questions about people who don't have access to an ELISA PF4 hit in their jurisdiction. What approach would they take?
Yeah, it's a really great and super practical question, Peter. Unfortunately, there's going to be some great work by folks across the country coming out with their experiences with this. Unfortunately, we're getting false negatives. I wish I didn't have to say that, but that is unfortunate that we are seeing false negatives. If you have a high index of suspicion, please contact hematology or thrombosis in your area, and we will talk you through it. We are really encouraging people to contact their lab and see if they can send out that test to get a reliable ELISA. And then, of course, MAC can help with the confirmatory testing, but you cannot rely on a rapid test. We have had some near misses around the world and in this country.
Okay. And then I think you answered some, or had some hints about second doses on what we don't know about second doses.
Yeah, I will say that people were hoping that the second dose would not be a problem if the first dose was uneventful. Again, I'm bearing more bad news. Sadly, there are now 4, as of today, reported cases of confirmed credible VITT after the second dose of AstraZeneca when the first dose was fine. Those are all reported in the UK through their yellow card systems. That's pretty reliable vaccine surveillance. So you need to tell your patients to be watchful for 28 days after both or any vaccination that they get.
All right, that's excellent information. Just trying to see if there's anything else that's repeated. So just, Menaka, say one more time. Are there risk factors for VITT?
Okay, not really. So there doesn't seem to be any signal when we look at the cases, but there are 2 important contraindications that Health Canada has just released for both Janssen and AstraZeneca. First, they recommend you do not get these vaccines if you have a history of heparin-induced thrombocytopenia, because we think there could be cross-reactivity. That's not proven, but it's a bit of a common sense contraindication. Second is if you have CSVT with thrombocytopenia, it is recommended you not get these vaccines. We have not seen that in any reported cases of VITT, Peter, but I think it is, again, a common sense piece of advice that probably won't affect a lot of patients. every other thing you can think of, trust me, is not a risk factor for VITT. We are learning more, but we now have quite a bit of cases, and there don't seem to be any risk factor signals there, unfortunately.
Right.
Great. Thank you so much, Menaka. And I'd like to thank our other speakers from this evening. This has been a great presentation from all of you. Thanks very much. And a recording will be available later this week on the Thrombosis Canada website and our YouTube channel. So many thanks to our speakers and our participants this evening. Have a good night, everybody. Thank you.